finish by thanking all of the clinical cohort team shown here who made this work possible. We have now started to link this data with imaging and also previous fellows who did a lot of the previous work. Thank you.
Hi, good morning, good afternoon, and good evening. Thank you for having me in this conference. Today, I'm going to talk about defining Parkinson's disease subtypes according to their biomarker signature. I'm Qinshan Lin from Taiwan. First, I have nothing to disclose. And before I talk about the biomarker signature for subtyping Parkinson's disease, I think we need to know the definition of so-called biomarker. The definition for it that the biomarker should be objectively measured, and theoretically and ideally, we need biomarkers that can help clinicians for proper diagnosis, for proper classification, and ideally to predict the prognosis, and even better to monitoring the clinical responses to the treatment or any intervention. So I think everyone is familiar with this clinical spectrum for Parkinson's disease. Although we now have many dopaminergic medication and deep brain stimulation that can largely improve the symptoms of patients with PD. However, patients will still deteriorate because they become more aged in either the motor function or in the cognitive function to even the state of Parkinson's disease with dementia. And we also knew that the blood pathology have told us that Lewy body may start from the gut or from the olfactory nervous system. So as we can see that patients may have the so-called premotor symptoms as early as 20 years before the onset of the classical motor symptoms. For example, the RBD, the hyposmia, the depression, and even the autonomic symptoms. For example, the gastrointestinal symptoms, that is constipations. So we know that there are many exciting and promising disease-modifying strategies that are going on. So I think it is good and perfect to isolate a specific group in this premotor stage for patients with PD, because in this time window, they can benefit most from these disease-modifying strategies. So in this case, we need biomarkers that can help us to predict whether the patients will progress very fast or even progress fast to the dementia, or they can predict they will become a Parkinson's disease in a premotor stage, because we want to isolate this specific group of patients because they will benefit most from disease-modifying therapies. So I want to cover 3 biomarkers who can help us to fulfill the ideal biomarkers for subtyping Parkinson's disease, that is including the neuroimaging biomarkers, biofluid biomarkers, and the genetic markers. So I think we have learned so much from the beautiful talk from Professor Hu from the first talk, that we use a lot of clinical subtyping in our clinical practice. So about recently, there's a beautiful study that has been done and has been followed up for more than 10 years, which is pathology proven of Parkinson's disease, that they enrolled more than 100 PD patients. And they subdivided these patients into several clinical subtypes based on their motor symptoms and non-motor symptoms. They subdivided into 3 types, including the most severe, the diffuse malignant subtypes, which means they have motor dysfunction and also have several non-motor dysfunctions, including the RBD, the autonomic dysfunction, and the cognitive dysfunction at the initial diagnosis. And they also have the mild category, which only have the mild motor predominant. And those groups in between, that will be the intermediate group. So during the follow-up period for about 10 years, they found that those in the diffuse malignant subtypes, they will have shorter survival time and will have a faster progression to several important disease milestones, including the recurrent falls, wheelchair-bounded, cognitive dysfunction to the stage of dementia, and even nursing home needed. So we know that clinical subtyping is useful for us to predict the clinical progressions. So another study that is using a database from the PPMI that enrolled more than 400 patients that is the novel and drug-naive patients. And they use the same subtypings of these clinical categories. And consistently, they found that people in the diffuse malignant subtype, they will progress more fastly compared to those subgroups. And furthermore, they try to compare these three groups using different biomarkers. For example, using the MRI findings, they use the DBA analysis, and they found in these three groups compared to the control participants, they found there is a specific PD-specific network atrophy, which is localized to the basal ganglion, the brainstem, and the orbital frontal region. That is severe atrophy compared to the control groups, and which is more severe in the diffuse malignant subtypes. They also examined the CSF biomarkers, especially focused on the amyloid beta 42, and they found that the level is lowest in the diffuse malignant subtypes. I think that is quite coherent to they have faster cognitive decline compared to other groups. So in this case, it seems that the clinical subtyping and neuroimaging are helpful for clinical prediction for the progression of PD patients. So another group, they also use the PDMI database, and they try to divide the patients into two subgroups. That is biotype 1, which means they have the MRI findings with smaller subcortical brain regions, especially focused on the bilateral basal ganglion, which are smaller than the controls. And the other group is on the opposite. They have the larger subcortical brain volumes, larger than the control participants. And they found, after follow-up for 5 years in this PPMI database, they found those in biotype 1, which have smaller subcortical region, they will progress faster compared to the biotype 2. So it gives us a exciting, encouraging data, since that neuroimaging, which is a widely available brain MRI, can help us as a kind of neuroimaging markers to predict the progression of PD patients. However, as for the first study, because they have pathological proven, they found although the clinical subtyping is quite useful for predict the progression of PD patients. However, the pathology findings, including Lewy body distribution and the Alzheimer's disease-related pathology, especially the tau amyloid, did not differ between the groups. So it means that we still need other biomarkers, which is a biological best biomarkers, in addition to the clinical subtyping and the neuroimaging findings. Although they are quite useful in clinical practice, but sometimes they does not consistently correlate with the neuropathology findings. So that's why we need to explore more and to identify more novel biomarkers. So in this case, there are several studies using two common approaches for identifying this kind of biomarkers. The first one is a data-driven approach, which is based on the clinical diagnosis, like we compare the PD patients with normal cognition or those with PD-MCI or PDD, and we isolated the specific different markers between these three groups. And we try to explain that maybe this marker can be a biomarker for this kind of cognition decline. This is the most commonly used approach for most studies. And the other approach is the hypothesis-driven approach, because we know there are many mechanisms that will contribute to the pathology of Parkinson's disease. But the common and the final executive pathways is the abnormal alpha-synuclein accumulations. So many studies have based on this kind of pathology findings, trying to identify whether there are pathological alpha-synuclein accumulations in different biospecies, including the blood, the CSF, the saliva, and even the gut tissues. So for these reasons, we can separate. There are two kinds of common targets that people or researchers commonly use for this kind of approaches. The one target is the neuropathology-related proteins that people will try to identify whether the expression level is different or not between different groups. And because Parkinson's disease, the main pathology finding is synuclein, So many researchers will try to identify the total form or the oligomeric form or the phosphorylated form of synuclein and the amyloid beta or tau-related pathology. And recently, the neurofilament light chain, which is a very sensitive marker for neurodegeneration because it is a cytoskeleton-related protein. When neurons start to degenerate, it will be released into the biofluids, especially the cerebral spinal fluid and the peripheral circulation. And another group of proteins that people often to try to target is the non-neuropathology related proteins, but related to the mechanism and based on the in vitro studies, including the mitochondria related or the oxidative stress related proteins and neuroinflammation process. And recently, the uric acid has been found to be beneficial and neuroprotective in vitro. So it has been examined in the biofluids in patients with PD. However, we know that for all these studies, either you are targeting neuropathology or non-neuropathology related proteins, all the data are sometimes inconsistent. I think one of the major reasons is different research groups using different platforms to detect this kind of ultra-low concentration of biomarker proteins, especially in peripheral circulations. So because of that, there are many inconsistent data. So we have tried to summarize the most promising and relatively consistent data. So before that, we will go back to several important pilot studies. For example, BRIT has beautifully demonstrated that if we check the total form of alpha-synuclein levels in patients with PD in the CSF, it is consistently showed that the CSF level of alpha-synuclein is decreased in patients with PD. And several similar studies followed. And the recent meta-analysis has found that the level of synuclein do really decreased in patients with PD compared to control. And among PD patients, the level of alpha-synuclein actually can correlate it with the cognitive function. It means that lower levels of alpha-synuclein will correlate with the worse cognitive performance in patients with PD. So in this study, like using the PPMI database, because that is a drug naive and have been longitudinally followed up for 5 years. And in these studies, they also subdivided patients into different genotypes based on the ApoE genotypes. However, in this study, the ApoE genotype will not differ between PD and control, and the CSF level of synuclein was similar without significant difference between different ApoE genotype. So since ApoE is not a major genetic determinant for PD patients with cognitive decline, but alpha-synuclein level in CSF do really seems to show it's a promising biomarker for PD patients with cognitive decline. So let's change the gear to the peripheral circulation. And several studies, including our group, previously have found that the total form of alpha-synuclein levels is increased on the opposite in patients with Parkinson's disease, and the level is higher in patients with advanced stage of Parkinson's disease in regards to the PDD or the Hong and Yaw stage 5 patients. And the follow-up study also showed the same findings. So the meta-analysis, they really showed that the alpha-synuclein level is slightly increased in peripheral circulation. So based on these neuropathology-related markers, another marker I want to emphasize is the neurofilament light chain. It is a very sensitive marker, but it is not specific because, just as I mentioned, it is a cytoskeleton-related proteins. So any cells, any neurons, when they start to degenerate, the cell will lysis and release the neurofilament light chains. So in our previous study, we compare the PD patients and control and another group of neurodegenerative disorder, that is multiple system atrophy, who has more widespread degeneration compared to Parkinson patients. And we do find that the blood level of NFL is highest in patients with MSA compared to PD and then the control. And the baseline level of the NFL can predict either the motor progression or the cognitive progression. So again, it is a neuropathology related biomarkers. On the opposite, several studies do really very hard try to identify non-neuropathology related biomarkers. For example, from a large, beautiful London cohort, the researchers have found that the neuroinflammation, such as the inflammatory marker, the C-reactive protein, are higher in patients with more severe phenotype. And the uric acid, as I mentioned, it is relatively beneficial in the in vitro studies. So it was originally found will be decreased in patients with more faster cognitive decline in a pilot study with a 4-year follow-up study level. However, in recent PPMI, a relatively large cohort studies, the uric acid level did not differ between the PD patients and controls. But among a subgroup of patients which carry the SNCA mutation, the uric acid level do really decreased compared to controls. So there are still some inconsistent findings, and I think we need other study cohorts to confirm the findings from the value of the uric acid levels in PD progressions. So we talk about the clinical subtyping is quite useful in clinical prediction, but does not match up with the neuropathology findings. We have the neuroimaging data, which may help the clinician to predict the progression. And we have the biomarkers in the CSF and in the peripheral circulation. Most of them are protein-based markers. And now we move to the final markers, which is the genetic markers, because we know that all these proteins are encoded by the genes, and the genetic network have contributed to the pathophysiology of the Parkinson's disease. So before I move to the genetic markers, there are a brief update about the recent genetic findings. Since the first genetic causative gene has been identified, there are more than 25 genes have been identified to cause either autosomal dominant or autosomal recessive Parkinson's disease. And based on these genes, if we look carefully about the protein functions of these genes, we can have a better understanding about the pathophysiology of Parkinson's disease may come from the protein degradation, the autophagosome lysosome pathway, the mitochondrial dysfunction, and the membrane, especially the Golgi, the ER, and the membrane trafficking pathways. So these findings are based on the relatively few familial Parkinson families. However, on the other hand, are a large population of sporadic Parkinson's disease. So using the GWAS studies, there is a beautiful meta-analysis collecting the 17 data set of huge GWAS studies in the European ancestries, European populations. And the study group has found that there are 90 risk genetic variants were identified related to the risk of PD. And among these 90 genetic variants, there are 3 pop out that are actually the causative gene for familial Parkinson's disease, that is SNCA, the LRRK2, and a GBA protein, a GBA gene. And a similar study was also conducted in the huge Asian samples from the Professor E.K. Tan in Singapore. And in this study, that is a huge Asian-specific genome-wide study analysis using the polygenetic risk score, they have found there are 11 significant loci related to risk of Parkinson's disease. And 2 of them have popped out, that is SNCA and LRRK2 again. So we have seen the GBA, and GBA is not actually the causative gene for Parkinson's disease, but it is actually the causative gene for a rare Gaucher's disease, which is an autosomal recessive storage disease, but it is by allele mutations. However, in previous studies, a multi-study from multi-centers have found if the carriers carry one single allele, heterozygous GBA mutations, when they get older, they will have an increased risk to develop Parkinson's disease. And the odds ratio will be around 3 to 4, which is a very strong genetic risk for developing Parkinson's disease. So for the genetic biomarkers, which can help us to subtype Parkinson patients, I would like to choose the LRRK2, the GBA, and the SNCA based on these genetic findings. So the LUG2 mutations, I think everyone is very familiar with that because it is an important mutation for autosomal dominant Parkinson's disease, and especially in the European and Western population, especially in Spanish Jews, there's a G2090 mutation, which is quite common in these populations. However, in Asians, we still don't have G2090S mutation, but we do really have other mutations also in the kinase domain and in the ROCK-GTPase domains. And we also have specific risk polymorphisms that will increase risk of Parkinson's disease. So LUG2 is also important in Asian populations. And the phenotype of these LUG2 mutation carriers are actually similar with idiopathic PD. As we can see, the age of onset is relatively late, and they often show good response to L-DOPA and deep brain stimulations. And all the pathogenetic mutations, either identified in Western or Asian population, they are also cause the abnormally increased kinase activity of LUG2, which is quite compatible with it is a toxic gain of function mutation and compatible with its autosomal dominant inheritance pattern. So in this case, people are very curious about, since it is a kinase, and if the LUG2 carry the mutation, it will have abnormally increased kinase activity. And what is the substrates of LUG2? And there are many substrates that have been identified, and among the LUG2 substrates, there are several interesting proteins that are red proteins, which can collaborate with BPS35 in regulating the membrane trafficking, the protein trafficking in the neurogenesis. And among these red proteins, the REP-A and REP-10 are important substrates for LUG2. So LUG2 is not only important for familial cases, and there's a beautiful neuropathology study that was published 2 years ago that they found that even in patients with idiopathic Parkinson's disease, if we check the phosphorylated LUG2, because it is a dimer, it will autophosphorylate itself. The phosphorylation level of LUG2 is also increased even in idiopathic PD patients' brain pathology findings. So this gives us a very exciting results that LUG2 is important even for idiopathic Parkinson's disease. So because of that, there are several LUG2-based biomarker assays have been developed. Several of them are related to checking the LUG2 protein levels, including the total LUG2 and the phosphorylated LUG2 protein levels in different biofluid tissues, including the CSF and the blood. And also there is an in vitro kinase assay, because we know that when LUG2 carry the mutation, or even in patients with idiopathic PD, the kinase activity of LUG2 will be increased. So there is already a commercially available kit that can check the LUG2 kinase activity. So if we want to identify easily accessible biomarkers, the blood-based biomarkers is most easily accessible. So this research group has found that among our peripheral circulations, the neutrophils and the monocytes have huge amount of LUG2 expression levels compared to other blood cell types. And very interestingly is the substrate of LUG2, that is the REP-10, is also highly expressed in the neutrophil and in the monocyte of peripheral circulations. So in this study, although it is a pilot study, but do really show promising results that they compare the PD patients compared to the control. And they found in PD patients from their peripheral blood, they will have an increased level of total LUG2 and the total REP-10 level, and even the phosphorylated REP-10 levels compared to the control. So it's a quite promising biomarker, because we know that the LUG2 kinase inhibitor clinical trial are just ongoing. So maybe this is a good candidate biomarkers for this kind of clinical trials. So let's move to the second genetic biomarker, that is the GBA. We know that GBA mutation carriers will easily develop Parkinson's disease, and the phenotype of the GBA mutation carriers have been found that will have a faster decline in cognitive functions compared to idiopathic Parkinson's disease. And because GBA encodes the glucose cerebrosidase, which is an important enzyme in the lysosome, So we know that the biallelic mutation of the GBA will cause Gaucher's disease, and there are enzyme replacement therapy for GBA. But unfortunately, the clinical trial for PD patients seems not promising. It is early terminated. But although it is early terminated, there are several biomarkers have been established to examine the blood GCS activities. So if we compare the patients with biallelic GBA mutations, that is the Gaucher's disease patients, they will have the lowest glucose cerebrosidase enzyme activity in peripheral blood compared to the heterozygous mutations, Parkinson disease, and then the controls. So in the future, if there are other GBA targeted clinical trials, I think the peripheral blood GCS activity is a good biomarker for this kind of clinical trials. So the final one, the genetic marker, is the SNCA because it is a gene encoding the alpha-synuclein. SNCA mutation families have been identified in several countries, and more than 100 families have been reported in the MDS genes, and most of them carry the alanine 53 threonine mutations, and the onset age is slightly younger in their 40s compared to idiopathic Parkinson disease. So there are many alpha-synuclein-based biomarker assays, as I just mentioned, in CSF or in blood, and there are several approaches for identifying alpha-synuclein, especially the phosphorylated form or oligomeric form in salivary glands and colon tissue and skin biopsies. But most of these data are still inconsistent. So we still need a large cohort studies to confirm their values in clinical practice. So I think I would like to summarize my findings that my talk today, that there are still a lot of challenges to identify biomarkers that could perfectly subtyping PD patients, because most of the studies are based on the data-driven approach, but sometimes the clinical phenotyping may be unstable. And for the longitudinal follow-up studies, there are several issues, especially patients may drop up. So we may not have completely follow-up data. And in addition to that, we did not counter in the environmental factors, which we know that they are also important risk factors for Parkinson's disease, and especially it's important for different affinities. So that is my final slide, that we now are in the subtyping, and we have several biomarkers, although it's quite useful in clinical practice. But in the near future, we should need an untargeted, unbiased, biological-based approach to subdividing the patients or from the agent population to obtain more objective biomarkers for PD patients. So in the future, I think we need this kind of non-biosystematic, bio-based approach. But currently, I think the genetic markers will be stable compared to other markers. But genetic combined with other biosignatures are suggested with a long-term follow-up cohort to identify a specific good biomarker panels to subtype PD patients. So I would like to thank you for all your attentions, and any comments and suggestions are welcome. Thank you very much.
Thank you very much. It's a pleasure to be here and speak to you today. And I will be first defining precision medicine, and then I'll talk about the state of the art of precision medicine of both clinical and genetic subtypes. And then I'll challenge us a little bit to ask ourselves why we are choosing subtypes as a basis for precision medicine, and whether or not we may want to strive for something different. Precision medicine is an approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle, as defined by the National Research Council Precision Medicine Initiative. And so what could this look like in Parkinson's disease as related to subtyping as a basis for precision medicine? Well, a person with a PD diagnosis would have to be classified into specific subtype. And then that would dictate or suggest a particular treatment combination. Recently, we reviewed systematically, as part of the task force for PD subtypes, the previously published subtyping systems. And this gives us an idea of how today we classify individuals into PD subtypes. And we found that in this review, the phenotypic domains that were included in the subtyping systems were largely demographic and clinical domains, and only a very small number of individuals or number of studies used non-clinical biomarkers for their subtyping systems and for being imaging biomarkers and one biochemical. And so this pattern is reflected in what I'll talk about momentarily as the basis for therapy of PD subtypes today, with a glaring absence of biomarkers in these systems. I should say that we didn't include genetics in this review, but I will. But it is an active area of subtyping, and I will talk about it in this presentation. So one of the most common bases on which to divide individuals with Parkinson's disease is age at onset. And young onset Parkinson's disease is usually defined by an age under approximately 45 or 50 years of age. And this is useful clinically in that these individuals are particularly susceptible to motor complications related to dopaminergic therapy. And because of this, it may be useful to consider dopamine agonists to delay motor complications. And this is in fact a common strategy, probably more common in the past than present. But if this is going to be contemplated, then we need to acknowledge limitations of this approach, particularly that after the initiation of levodopa, the incidence and severity of motor complications are no different regardless of the initial treatment strategy, that dopamine agonists are a less effective approach compared to levodopa for the motor aspects of Parkinson's disease, and that dopamine agonists tend to have more adverse effects, especially in younger people, considering the propensity for impulse control disorders, or ICDs. It's also important to screen frequently for depression in these younger individuals, given that they are particularly prone to depressive symptoms. And this may not only be the underlying biology of their disease, but also may reflect the major adjustments that they must face in occupational and social life related to a neurodegenerative disease at this time of life. And it is these challenges that have inspired the creation of an MDS task force on early onset Parkinson's disease to identify these challenges. And so this task force is just getting up and running, and we hope that their findings and summaries will help to flesh out the care recommendations for this specific subtype. Older onset individuals are more prone to cognitive problems, which calls for caution when using treatments such as dopamine agonists, anticholinergics, or deep brain stimulation. And in this group, it's important to consider the role of co-pathology, such as Alzheimer's disease or cerebrovascular disease, if atypical cognitive or motor features appear. For example, prominent episodic memory complaints in somebody with Parkinson's disease. And this can prompt appropriate referrals to colleagues with expertise in these areas. I just wanted to draw your attention to a very useful review paper that was published not too long ago that contrasts young onset and late onset Parkinson's disease. And there are more differences than I've just mentioned. And these differences, mainly the clinical implication is monitoring and early detection for these. So if clinicians are aware of differences in propensity for specific symptoms, we can target our monitoring appropriately. In the motor sphere, Parkinson's disease is often divided into tremor dominant and postural instability gait disorder types. And the tremor dominant type may cause us to come across levodopa refractory tremor, where anticholinergic drugs, clozapine or DBS may be useful therapies if the tremor seriously affects quality of life. In the PIGD subtype, it's logical that an early referral to physical therapy is a useful and important strategy. But also important to remember is that PIGD subtype is associated with a higher burden of non-motor symptoms than the tremor dominant subtype. And again, calling for monitoring for these symptoms. The most consistent observation is an association with cognitive decline, but also various other non-motor symptoms have been found to be present in higher frequencies, but the specific symptom varies from study to study. So further work is needed to see which findings are most replicable. From the non-motor point of view, unidimensional categorization of people with Parkinson's disease into, quote, subtypes has been proposed, but it's more useful perhaps to define subtypes on the basis of symptoms or markers that co-occur within an individual, as it allows for a more tailored or focused monitoring for other symptoms. And largely this work, their framework that I'm showing you here, is largely the work of Ray Chaudhry and Natalia Titova, who have brought together the knowledge about the co-occurrence of non-motor symptoms, and also further what we know about the underlying neurotransmitter deficits that determine these symptoms, at least in large part. So they have defined a cholinergic subtype that's characterized by the common co-occurrence of cognitive decline and falls. And so in this subtype, it's proposed to avoid anticholinergics or drugs with anticholinergic properties, which makes sense. In those with established cognitive impairment that impact on activities of daily living, one can consider cholinesterase inhibitors such as rivastigmine, and the E there represents a classification of efficacious for this treatment suggestion based on the MDS evidence-based review. Because of the propensity to falls, bone health screening to ensure osteoporosis is optimally managed is important, as are physiotherapy and exercise programs that focus on gait and falls prevention. They've also posited a noradrenergic subtype, which underlies dysautonomia, gastrointestinal dysfunction, and also is associated with REM behavior disorder. And in these individuals, monitoring for postural hypotension is very important, as we know the morbidity that can arise from postural hypotension, and not only from fatigue and feeling dizzy and lightheaded, but also the propensity to falls. And this can be treated as required with agents such as droxidopa, a prodrug of norepinephrine. We should monitor for constipation, particularly in these individuals, given their predisposition, and the same applies for delayed gastric emptying. Because of their association and high frequency of REM behavior disorder, specific screening and counseling ahead for what this symptom looks like is important. And then finally, a serotonergic subtype has been proposed, with serotonergic deficits contributing to somnolence and fatigue. And in these individuals, the avoidance of agents that can cause sudden onset sleep or promote excessive daytime sleepiness makes sense, such as those dopamine agonists with D3 activity, pramipexole and ropinirole. In addition, important to provide lifestyle advice for those individuals getting themselves into situations where sudden onset sleep could produce a safety hazard. And then with respect to fatigue, active screening for fatigue and then treatment with rasagiline may be a useful strategy for these individuals with disabling fatigue. And in anyone with fatigue, also evaluating sleep as a poor sleep as a contribution and treating sleep disordered breathing, if it is present, is important to be aware of and keep screening for. So I'm going to switch now from the clinical to the genetic subtypes of Parkinson's disease. And as you can see in this slide, the genetic architecture of Parkinson's disease is extremely complex, with over 90 independent risk signals being identified to date. And then also in the upper box is a series of what we consider to be causative genes. Particularly the two most common genes considered to be causative are monogenic causes of Parkinson's disease, LRRK2 and GBA, are the subject of subtype-specific therapeutic development. And the following slides summarize what is ongoing in this field. So you can see that with respect to LRRK2-related Parkinson's disease, phase 1 studies are either complete or ongoing with LRRK2 inhibitors, as well as an antisense oligonucleotide strategy to reduce the expression of LRRK2. And so far, the LRRK2 inhibitors have shown no significant safety concerns, and the antisense oligonucleotide study is in progress. So hopefully we'll see continued development in this area. With respect to GBA-related Parkinson's disease, the folk that codes for glucocerebrosidase, the focus is on restoration of enzyme function, and various different strategies have been undertaken to try to make this happen, including enzyme replacement therapy, gene therapy, and small molecule chaperones. In the case of neurological symptoms, the most promising strategies appear to be those to date of gene therapy and the small molecule chaperones. And in this area, again, we are in the phase 1 and phase 2 space with trials with glucocerebrosidase activators and gene therapy with a GBA viral vector in progress, and unfortunately a glucosyl ceramide synthase inhibitor study to reduce substrate having been terminated early for lack of efficacy. The agent Broxol, which has already been used in humans as a mucolytic agent, is also a GK chaperone and is in phase 2 studies, one study being completed with a reasonable safety profile, and then another study in progress. So these are promising findings so far, and hopefully we'll see continued development. And you can see that this is an entirely different approach of substrate-specific therapeutic development in the disease-modifying realm versus the purely symptomatic therapies that I presented earlier based on traditional PD subtypes. Coming back to symptomatic therapies for a second, though, because we shouldn't forget them, they're important. GBA, Parkinson's disease, is associated with a higher frequency of cognitive impairment, and thus it's prudent to avoid use of anticholinergics and dopamine agonists in those who have mild cognitive impairment or frank cognitive impairment. So screening for these is important. And caution is warranted in the use of DBS given the findings of poorer cognitive and functional outcomes in these individuals. The genes Parkin and PINK1 are important in mitochondrial function, and the mutations in these genes are associated with mitochondrial dysfunction. And to try to address this, there is one study that has been designed to enroll individuals with either compound heterozygous, homozygous, or heterozygous Parkin and PINK1 mutations to coenzyme Q10 or placebo. And there are also two other arms here named omics arms, where individuals without mutations in these genes, but with omics evidence of mitochondrial dysfunction or lack thereof, are also being included. So this study is in progress, and hopefully we'll have something soon that's tailored for these individuals. All right, so I've talked about genetics in terms of causative genes, but there are a lot of other genetically related associations that we need to consider. So for example, susceptibility to symptoms and adverse effects is often a basis for personalized medicine in other fields to guide choice of therapies. And so we do have a knowledge base in this area in Parkinson's disease, where we are aware of polymorphisms that are associated with cognitive decline, with visual hallucinations, sudden onset sleep, impulse control disorders, for example. And I could probably list others that are not here. But the important point here is that, to my knowledge, these are not currently incorporated into Parkinson's disease clinical practice. And we should ask ourselves why. I mean, maybe it's a resource issue, but I think that we need to strive to use the knowledge that we have to try to tailor therapies. Indeed, it's been even more studies in this area have been called for with improvements in pharmacogenetic study design, calling for hypothesis-free studies, genome-wide studies of pharmacogenetics, looking for genetic factors associated with treatment response and adverse effects. And these will require very large sample sizes and replication studies. So clearly we can strive to do better in terms of acknowledging the complex genetics of Parkinson's disease and associated treatment responsiveness. I alluded earlier to our MDS task force on PD subtypes, and we've, in the process of reviewing this literature, we generated several recommendations that bear specifically on treatment of Parkinson's subtypes. And one of these is to use findings from data-driven studies to define their clinical applicability and biological underpinnings. So you may have noticed that there was a striking absence of mention of data-driven subtypes in my review of subtype therapeutics in Parkinson's disease. And so, although there are many data-driven subtyping systems that have been published, they've not been used specifically to investigate how they impact or how they can be used to personalize therapies for people with Parkinson's. This may be due to their complex multidimensional nature and thus difficulty classifying individuals in the clinic into these subtypes. But if so, I mean, this needs to be, this is a limitation that we should strive to overcome in order to see if these subtypes are indeed useful in this respect. We've also called for biologically based subtyping studies to move beyond symptomatic therapy. This is being done in the genetic sphere, but needs to move on beyond also genetics. And furthermore, studies examining the prognostic or biological relevance at the individual level are needed, because when you're faced with a patient in your office, this is an individual, not a subgroup, not a subtype. And if we think about at least the unidimensional subtypes that I reviewed earlier, age at onset, for example, motor subtype, the individual sitting in your office can be put into multiple categories, right? And not just a single subtype. And so far we haven't really examined the how to manage this at the clinical level. And so this sort of brings me to the current limitations of subtyping and how we can maybe think beyond subtypes for personalized medicine or precision medicine in Parkinson's disease. We are moving beyond a one-size-fits-all to a subgroup strategy where we're trying to put people into a manageable number of subtypes. But I would argue that given the biological complexity of Parkinson's disease and the resulting huge clinical heterogeneity, trying to constrain Parkinson's disease to a restricted number of subtypes is probably not going to be reflective of reality, and we need to think at the individual level. This is being done beyond Parkinson's disease in a huge program in the United States called All of Us, where over 1 million Americans are being recruited to a study to contribute multiple different biological samples, physiological, lifestyle, environmental measurements, as well as links to medical records in order to make a database that can inform the development of individual-based precision medicine. And maybe we can be thinking to do something similar in Parkinson's disease, and indeed, as I'll show you in a minute, this is being done. So what could this look like in the clinic? We could imagine one day that we have a Parkinson's disease patient who we lead through clinical subtyping from the motor and non-motor symptom point of view to guide symptomatic therapy. But in addition, we apply relevant biomarkers, whether or not they be molecular imaging, genomic, or other omics data, to then determine a subtype-specific treatment, and then tailor this based on individual preferences and lifestyle. But there are challenges, significant challenges to this that we need to overcome before we can implement it. One is the limited ability to phenotype Parkinson's beyond clinical features currently. So we do have some biomarkers, but not a great deal. And their impact or their implications for therapeutics is currently largely undefined. We currently recruit patients to clinical trials who are poorly representative of the Parkinson's population, especially with regards to race and ethnicity and social determinants of health. The sample size requirements to develop the knowledge, the evidence to tailor treatment at the even subtype, but further the subtype or individual level is huge and beyond what we currently recruit in general. So we would need to improve recruitment processes through better awareness of research opportunities, education, and likely decentralizing trials. And this latter is a movement that's already afoot. Fortunately, there are a number of efforts to improve the awareness and participation rates of people from racial and ethnic underrepresented groups into clinical research. And I've just shown you a few of them here. And we also have genetic programs, which are aiming to expand the genetic testing of people with Parkinson's disease to provide clinicians and patients with genetic results that can allow us to be aware of who may be candidates for the inevitably upcoming genetically based therapies that are going to be tested shortly. And so this is an example of the PD generation study, which is doing this, and there are other efforts as well that are underway to make genetic testing more widespread. And then finally, I wanted to show you the example that I think of when I think of the All of Us initiative in the United States. This seems to me like the Parkinson's equivalent of that, or it's certainly analogous, where Bas Blum and colleagues are recruiting over 600 people with Parkinson's disease to multidimensional phenotyping, including biomarkers, clinical phenotyping, MRI, and other physiologic data collection. And their goal, as you can see at the bottom, is to identify biomarkers to predict treatment response in order to provide PD patients with a more precise and personalized disease management approach. So all of this is very encouraging to me, and I think wonderful steps towards precision medicine in Parkinson's disease. And I think we can think beyond subgroups and more at the individual level. Thank you very much for your attention, and I'm happy to take questions.
Hello, everybody. Thank you for joining us for this plenary session on the heterogeneity of Parkinson's disease. I think you would agree with me that we have had 3 excellent talks that have been given, and we thank you very much for the 3 speakers, Drs. Michelle Hu, Chin Xian Lim, as well as Connie Maras. We are here to take some questions, so we thank you for many questions that have come in, and we will be taking these questions in turn. So for Dr. Michelle Hu, there's a question from Alberto Aspe that if subtyping is a way to reckon with the variability of Parkinson's, shouldn't clustering and analysis hold together without disintegrating over time? And shouldn't each of the resulting subtypes be supported by high rather than just some underlying biological homogeneity?
Yeah, I think that's a great,
yes.
Thank you very much. That's a great question from Alberto. I think we recognize the limitations of PD subtypes in that we are fitting a model to perhaps 3,000 patients here, but there will be individual differences both in the underlying biology, clinical presentation, and progression. So I do believe that fitting subtypes on a group level will give us some information both about presentation and subsequent progression about underlying pathophysiology. But I think ultimately we will get more information by moving to an individually determined fingerprint or biological fingerprint of each individual. And that can include progression, clinical phenotype, genetics, and underlying biology. However, just as the underlying biology is not going to be composed of a single protein disorder, for example, like alpha-synuclein, which will be contributing to the patient's presentation and progression, I would argue the fact the subtypes change over time probably reflects partly the underlying pathophysiological drivers as that patient moves from prodromal to manifest to complex Parkinson's. So I think we have a lot to take this area forward, but I still wouldn't discount the information we can get from subtyping in a general way.
Great. I'll ask the next question then. This is to Professor Lim from Professor Lim. Thank you for this excellent and very informative talk, Chin Sen. I certainly agree with that. The question is, given the growing evidence on fluid biomarkers, how can you advise on how we should organize our biobanking? So in other words, in a resource limiting setting, how should we prioritize what fluid to store? Serum versus plasma, leukocytes, exosomes, CSF, urine, etc.
Yeah, thank you very much. I think the question comes from the Ai Hui. That is a very good question because I think every medical center cannot accommodate all sources of this kind of biofluids or biotissues. But for clinical practice, if we want to really longitudinally follow up patients or even the normal elderly population, I think the peripheral blood samples is necessary. And if patient can also provide their cerebrospinal fluids, that would be perfect as well, because it is quite easy to take the CSF fluid compared to take the gut tissues or other tissues from the human bodies. So that would be perfect to use this kind of bio tissues as a kind of follow-up as a major sources of biobank. Thank you very much.
Thank you. Thank you for answering. So Connie, I think there was a question here about whether there's any digital twin project to help with precision medicine in Parkinson's disease.
Yeah, I'm personally not aware of a specific digital twin project. I know this question comes from Panita. And, you know, it's certainly that I'm aware that there are twin cohorts that have contributed greatly to the epidemiology, understanding the epidemiology of Parkinson's disease. But specifically, I'm not aware of twin projects going on currently related to Parkinson's disease, although one could imagine that trying to understand the, you know, in mono and dizygotic twins, differences that that determine progression and, you know, going beyond what we've generally used them for, which is understanding incidence and risk, could be very helpful. To be looked for, I think.
Great. A question to Professor Hugh from Maria Stamilou. What do you think is the role of co-pathology in the more aggressive clusters, and how can we account for that when we're including patients in trials? So I think co-pathology, amyloid, tau, etc. How can we account for this?
Yeah, I think this is a really great question because we need to be able to bring in co-pathological drivers. And of course, it's not a clean proteinopathy, Parkinson's. So one of the ways we're looking at trying to address this is by looking at protein seeding aggregation assays, which can be measured in biological samples like spinal fluid. Because what these are able to do is give not a simple concentration as you would get from an ELISA antibody based test, but they're actually able to give aggregation potential for that patient's misfolded alpha-synuclein in the sample. And they may also be able to tell us about co-pathology. So we're looking at developing a multiplex protein assay in collaboration with Laura Parkinen using RT-QuIC, which is a type of assay to look at these, the seeding potential of protein, not just for alpha-synuclein, but also for tau and amyloid. And I think it's also very important to think about concomitant pathologies like vascular disease. We found that they are quite important in how a patient presents and subsequently progresses. And so we're looking at things like Q-risk score. We've also developed an automated imaging sequence that can look at white matter readouts on a simple MR of the patient and give an idea or a measure of vascular risk. So I think to really try and dig deeper, we need more specialized assays in combination with probably imaging and potentially also for centers that are lucky enough to access that, functional readouts with, say, PET or SPECT imaging.
All right, over to Professor Lim now. So there's a question about biomarkers. Given the non-specific nature of the biomarkers you elucidated, will it be worthwhile collecting and comparing this data in a matched cohort of normally aging adults?
Yeah, thank you very much for the good question. Again, I think it's quite important to compare the patient with Parkinson's disease compared to the age, gender, and maybe affinity matched the so-called normal elderly population with the longitudinal follow-up. As we, I think, already have the PPMI study cohort, I think it's also necessary to have the so-called normal elderly population to regularly follow up as well. And I think maybe it's quite important to follow up not only their clinical presentations, but their also imaging data and the multiplex panels from their biofluids, including the blood and the CSF. So as Professor Hu just mentioned, not only the alpha-synuclein, but other neuropathology markers, Alzheimer's disease related or the stroke disease related, and the neurofilament light chain, and the neuroinflammatory or systemic inflammatory markers as well important, because if the patient have the prodromal symptoms of the gastrointestinal symptoms, because of the gallbladder acids can also cause the systemic and even promote the neuroinflammation. So I think because the neuroinflammatory markers, for example, the pro-inflammatory cytokines can be easily exempt from the peripheral blood. So I think if the budget is allowable, I think it's important to accommodate these markers as well. Thank you very much for the good question.
Great, and I'll move to Professor Maris. Connie, thanks for your talk. This is related to pramipexole and fatigue. So in your slide, the fatigue is attributed to serotonergic insufficiency, so therefore pramipexole might be avoided. However, pramipexole is also encouraged to be used in PD patients with depression. What's your idea about this?
Yeah, thanks for this question. It's very highly clinically relevant, of course. My own suggestion would be that if depression is requiring treatment, that we probably preferentially should be using antidepressive agents that have been shown in clinical trials to be effective for treating Parkinson's disease depression. There are a number of these, and perhaps consider pramipexole to be a possible adjunct. In those with prominent fatigue, I would, even in those with depression, I would probably avoid using pramipexole and favor the use of specific other antidepressive agents. So I think just a matter of sort of weighing the severity of the two symptoms and finding the best balance there. Can I, Ron, before I lose the audience, can I just come back to Panita's question regarding the digital twin project? I had the opportunity after the question to Google digital twin, and I see that it's actually a specific technological approach that I'm actually not aware of. And maybe her question could be redirected to one of the other presenters who may actually know about digital twin technologies and whether or not they have been applied to PD.
Perfect.
Do the other two want to address this question about digital twins? Okay, maybe it's something that we need to look into, for future. I have two talks on CRP for Professor Hu. So two questions, sorry, on CRP. One would be, would yearly CRP monitoring be beneficial in a patient you project to deteriorate? Say a PD patient on the 4th to 5th year on levodopa, in the future, in the sense that one might use such data in forewarning the patient as to what to watch for. There's another question, if I can find it. Questions have kind of run all over the place, I think, but the other question on CRP was whether this will be affected by ongoing inflammation in the body, and whether I think the question was whether it could be confounded by that. Yes.
Yeah, absolutely. I mean, I think we're dealing with a group of patients who have many disease comorbidities, and that could be responsible for the raised C-reactive protein and the reduced apolipoprotein A1 that we reported in the more aggressive baseline subtype. So we have all the serum banked in our patients and controls. I think the first thing to do would be to definitely get a budget to look at it in the control matched age and gender matched and disease comorbidity matched control population, and then also to look at it longitudinally. And in particular, what I think would be most interesting would be to look at the patients with prodromal Parkinson's in our cohort and others who have RBD, because what would be really fascinating would be to look at where the pro-inflammatory changes are manifesting in which stage of disease. We seem to see it in the prodromal patients, suggesting that if it is particularly relevant there, that it might be that neuroinflammatory medications are going to be more effective or targeted at a prodromal disease stage. But we need more longitudinal data to really kind of prove that. And in the study we published, we basically had a budget just to do it in our PD patients. To try and sort of refine it a bit further, one could look at inflammatory changes in spinal fluid. And we are looking at potential and applying for a budget to do that. I should say the initial work was published by an innovation grant from Parkinson's UK. So lots of thoughts about how to take that further forward and helpful comments.
Great. This is a couple of questions that was given to Professor Lin, but they have a universal aspect. So maybe Professor Lin, you get the first chance, and then maybe the other two could weigh in. They come from Maria Stamlu and Jen Ling Li. So the questions go around the heart of what is the best subtyping solution. So Maria asked, do you think genetics will be the key in subtyping? And if yes, given the influences of epigenetics and disease mechanisms, even within the same patients in the same family. And then similar, maybe more general, the others can respond to is from Lynn Lee. Do you think it'd be better to subtype patients based on LRRK2 or GBA or clinical phenotypes? This is a good think piece for everybody, but I'll give you the first crack at it, Professor Lynn.
Okay, thank you very much. Thank you for Maria's very tough question, but it's very important. I think everyone knows that even you carry the most prevalent mutation, for example, the SNCA or LRRK2, the penetrance is not completely 100%. So it related to the expression of the mutation. So in addition to the epigenetic effects, especially the methylation levels of the SNCA, I think we also need to consider about the modifier genes. So because I think during this Congress, there are several groups of the International Genetic Consortium that we can pull together all the genetic data, and maybe we can have a kind of promising wish that we can find a specific genetic modifiers for this mutation that could possibly be combined with this important genetic mutation as a kind of markers. However, if we get back to the question, I don't think the genetic mutation per se is the only determinant for subtyping PD patients. Even for those carry the SNCA or LRRK2 G2090S mutation, their penetrance is not complete. So I think for my personal point of view, maybe we can ask about Professor Hu and Connie's suggestions that I think we may need to have integrated markers, combining the genetic markers, and the so-called genetic markers will depend a little bit on the affinity, because the genetic background is different between the Asians and the Western populations. And for the biofluid panels, I think the multiplex panel combining the neuropathology markers, including different forms of alpha-synuclein, not only the total or phosphorylated form, but also the oligomeric form of alpha-synuclein is quite important. And I personally think the neurofilament light chain is very sensitive, although it is not specific for Parkinson's disease, should be combined together. And in addition to that, I think clinical subtyping is also important, although sometimes it does not match to the neuropathology. But if patients have preceding the RBD or some other very bad non-motor symptoms, as Professor Hu just mentioned, in the cluster 3, they will have a rapid deterioration for their clinical projections. So this kind of clinical subtyping could be merged together and maybe use the kind of AI platform or intelligence can help us to subdivide these patients in a more comprehensive ways. Thank you very much. This is my personal opinions.
I'll throw that out to the other two of you. And if you have to pick, is clinical or genetics better at subtyping patients? If I could make the questions that harsh, or how could they be integrated, maybe as a more general one?
Sure, I can give you my opinion on it as well. I would agree with Dr. Lin's overall view that that we need to integrate these. I think right now there is no better or worse, and I think that will continue to be the case. I think it depends on the application. So if we're, for example, choosing candidates for LRRK2 specific therapies, GBA specific therapies, we may be able to do something as simple as their genotyping, although that's probably an oversimplification too. But if we're talking about prognostication, as Dr. Hu has emphasized in her talk, we may be needing to integrate things, very broadly in a multidimensional kind of way. And I think what we don't know currently is how these different genetic factors interact with the clinical features early in the disease to determine prognosis, although we're getting there. I mean, the data that have been presented in the session today have shown that we're working on this, but we need a better understanding of how these all interact and how they should be integrated.
Yeah, I would also just add, oops, sorry.
No, go ahead. Yeah, any thoughts?
Yeah, I was going to add, I think it's impossible at this stage in time to say which particular inputs into a prognostic or diagnostic model are going to be most effective. Because, for example, we really still don't understand a lot of the hereditability, the genetic input to Parkinson's. There's a lot we still don't know. Large kind of future studies which are in progress, like GP2ASAP, will start to uncover this. I think we also need to just think about putting in digital factors to the model, because clinical rating scales are quite subject to variability between an individual, depending on the time of day, and between raters, and often are very sparse. So I think that the advantage of having home-based digital, web-based cognitive function, for example, at a higher density granular level, will also lead to more accurate modeling data. So it's the integration of digital, clinical, phenotypic, genetic, imaging, all of this into a polymodal biomarker. Cancer has never achieved this with a single one biomarker fits all approach, and Parkinson's is arguably even more complex than cancer, and even more difficult to diagnose pathologically.
So thank you for your answer. Actually, I have a burning question related to that as well, because the question is about biomarkers. Do we use biomarkers? Can it help us in defining a subtype, a cluster, or do we use it to validate it? Because so far we have been defining them clinically, and I think using biomarkers to kind of validate it. So how do we proceed with this? Is it biomarkers, can it really be defining, or do we use it more as a validation tool? So I'd like to hear your views as well. Yeah. Actually, this one is actually Connie can start first, because it's supposed to be Connie's question. Yeah.
Absolutely, sure. I think the answer is either or, and I think that there are people, as you may know, we have pulled together a task force for PD subtypes with many of the experts in the field who are contributing. And I've seen in our conversations that some people view subtypes as outcomes and some people view them as predictors. And so, you can think about the, and there are fans of the biologically based subtyping, and there are fans of the clinically based subtyping. And depending on where you start, you can use either as a validation for them. And I think it goes back to the fact that we can use these for different purposes. If you use biologically based subtyping, you're driving at trying to understand the pathophysiology of the disease. If you use clinically based subtyping, you're aiming to try to guide clinical therapy or prognostication. And so then I think that the answer is, both.
Any quick replies from Chin Xian and then Michelle?
Maybe I go first, then Professor
Yes.
Hu. Yes, I personally think that the so-called biomarkers should be objectively measured and cannot be changeable or fluctuate a lot between different centers. So for the biofluid markers, especially for the blood samples, I think everyone knows from the previous literature, the data is often very confusing or contradict with each other. So if we do really want to establish a very objective platforms, I think a standardized platform should be suggested. In addition to that, the storage of the blood samples or even the CSF samples is important, because some study group will use the fresh blood or CSF samples, but some study groups they use the storage maybe more than 3 years or 4 years, even in a very ultra low temperature concentration. But I think the data will still be changed. That is my personal opinion.
Thanks. Michelle?
Yeah, I mean, I've often wondered about turning it on its head and just using the biomarkers to drive the phenotyping. I think if you could do this by looking at normal aging populations and seeing what happens over time with all of these approaches we've discussed. My concern is that that would really take another decade of proper cohort work, and it may end up actually with just as muddied a protein pathophysiological driving sort of mechanisms to multiple different phenotypes. So I think if we were going to do the reverse, i.e. letting biomarkers drive phenotypes, this would need considerable investment and a kind of almost a sea change to start looking. Now, obviously, there are a number of fantastic cohorts already out there. UK Biobank springs to mind, where this sort of data could actually be harnessed. And then, you could sort of start to upscale findings, say, in a PD cohort to what you're seeing in a general aging population. So that integration link at the moment is missing for me, and something I think we could exploit in future research.
Thank you.
Great. I'll stay with you, Michelle. A question coming from Jesse Cederbaum. It's an interesting question about sort of missing sources of variability that we haven't found yet, so we can generalize it as well. The question is, known genetic factors appear to account for relatively little variability in your model. And how can you plan to determine what other factors might differentiate the clusters, particularly with rate of progression?
Yeah. So we have, working with Michael Lawton in Bristol, we've actually started by trying to tackle in a very simplistic way the underlying genetic drivers of our PD subtypes that we've described. So we started off sort of almost having an a priori hypothesis that we would look at the two commonest monogenic mutations for PD, that's GBA and LRRK2. And then we calculated genetic risk scores for Parkinson's, but also across other disorders like MSA, PSP, dementia with Lewy body, and AD. And then we looked to see whether these polygenic risk scores varied across the four cohorts. So actually, the main consistent finding is that the most severe disease phenotype had the highest rates of GBA mutations, while the milder disease subtype had the lowest ratios. But if you use genetic risk scores, the severe disease phenotype has a reduced genetic risk of PD, which is absolutely fascinating because, why is that? Is that because these are all atypical patients and we've misdiagnosed them? Well, if that was the case, we'd expect that they would have a higher polygenic risk score for, say, atypical PD. That wasn't the case. So, again, what I come back to is the fact that a lot of the genetic studies where you've started to compile genetic risk scores are done on perhaps a bit of limited clinical phenotyping and on different disease cohorts, possibly not at an early stage, but later on. So these are all sort of potential confounds. So just to tackle it on a genetic basis alone, I think we're going to need higher level genotyping, moving on to things not just like genetic arrays, but whole exome-seq and whole genome-seq to sort of really start to dissect this. So that's just an answer in terms of the perspective of genetics alone of this very complex subject.
All right, thank you. We have time for just the last few questions. Back to Professor Lin. So there's a question about how do you think peripheral GCase activity will be useful in clinical trials as a biomarker for patient selection, target engagement, or response to drug? Are you able to help us answer that?
Yes, and thank you very much. I think this question is from Ziv. I personally think that it should combine with the genetic markers. If you do really want to start with Ambrosio or something like that for a patient carry specific GBA mutations, I think it is reasonable to check their GCS activity from their peripheral blood. So for this kind of clinical trial, I think to select a specific subgroup of patients that we think they will benefit most from this mechanism target therapy should be, in my opinion, that will be those who carry the GBA carrier or GBA mutations and with very low GCS activities. And I think this subgroup of patients will benefit most from the clinical trials of the GCS activity or Ambrosio. That's my quick answer. Thank you.
Great, Connie, again, a new question about environmental factors and whether they should be considered in precision medicine. So do you have a point of view about including environmental factors, population background in precision medicine?
I do. Yeah, I do for sure. So there are, although limited, there are suggestive data that a number of different environmental exposures have a correlation or association with progression of Parkinson's disease. And So I think that it will be important to, if we want to try to fingerprint an individual, I think there are certain environmental factors that may prove important, but it hasn't been these, again, we haven't come to the point yet where we've taken a comprehensive look at genetics, environment, baseline clinical features, and pulled them all together to see which ones are, really driving prognosis. But from the data so far, related to, for example, pesticide exposure, traumatic brain injury exposure, there are suggestions that these can be prognostically important. So I think that they deserve attention, as well as all of these other factors that we've been talking about.
I think we had a really excellent time discussing and asking questions. I just remind everyone that there's another session tomorrow that will be a repeat if you missed these talks, and also these talks are also available on demand. So I'll pass the time to Ron to close the session.
Great. Yes. In the last minute, I just want to say thank you very much for these three speakers. I must say, when I saw the topic, I thought, wow, those are hard topics to talk about, because these are fields very much in evolution. There's much to be done. And I think all three did a fantastic job of providing, the way forward, at least to understanding how our patients differ. So just in closing, as a final reminder to those who were there, please fill out your evaluation forms. They're done online, obviously. And we look forward to joining you in the next session. And thank you, everyone. Thank you very much.
I think there's also a reminder that there's actually a discussion at the end of this. So there's a post-session discussion that you can continue to have conversations among yourself or with the faculty. So I think there is a way that you can join that and you can interact and discuss with one another further, because we do not have a chance to address all the questions. So thank you.
Thank you.
Thank you very much.